All right, more drugs. This time we'll dabble into stimulants, cardiovascular drugs, antidepressants, and antihistamines. Stimulants have been used for ages. Ancient Mayans used to chew the leaves off of coca plants to relieve their hunger and fatigue, coca being the derivative for cocaine. Ethiopian nomads had their herds graze on the beans of the coffea arabica shrub, which we know better as the main ingredient in coffee. Opposite of sedatives and hypnotics, stimulants activate the central nervous system. They can treat many conditions other than sleep issues like obesity, attention hyperdeficit, attention deficit hyperactivity disorder, and colds with medications like Claritin D. Stimulants come with adverse effects, which may include anxiety, irritability, headaches, dizziness, tremors, insomnia, disturbing dreams, hallucinations, and paranoia. Like many substances, patients can develop a tolerance and dependence to stimulants. Often the same stimulant is indicated for multiple therapies like methylphenidate, Ritalin. It can treat narcolepsy as well as can be used to treat ADHD. There are a lot of substances in the stimulants class that, as of this date, have no safe therapeutic use due to the high potential for addiction and altered consciousness, which would include LSD, PCP, and THC, all of which can produce bizarre thoughts and hallucinations. However, it is ironic that addictive substances like opioids and opiates, which can kill people through just toxic levels being prescribed, substances like THC or cannabis and compounds similar to psilocybin or magic mushrooms and ketamine are currently being researched in psychiatric circles for mental health reasons. Psychomotor stimulants such as amphetamines, cocaine, and caffeine can cause serious health implications at higher doses. The worst scenario is death from overdose. You can overdose from toxic levels with all three of those substances. Yes, caffeine included. Stimulants are further classified by how they work or their pharmacological action. Stimulants are prescribed to patients who present with sleep related complaints such as narcolepsy, idiopathic hypersomnia, sleep apnea, or some circadian rhythm disorders. Studies have been shown that stimulants reduce excessive daytime sleepiness, which is a core symptom of idiopathic hypersomnia and narcolepsy, as well as poor sleep overall. Subjects report to feeling more alert, less bored, and even euphoric at higher doses. Simple motor tasks may improve along with attention to specific objects or behaviors. Again, different people respond differently to different drugs. One person may have a favorable reaction to a stimulant for their ADHD issues, but another person without ADHD may receive no benefit at all from a stimulant. Probably the most popular stimulant, caffeine, is also known as a nootropic or nootropic, which is a substance that improves a person's brain functions like memory, attention, and executive function. Common side effects that occur with the typical dosage of stimulants include anxiety, headache, irritability, heart palpitations, and tremors. Stimulant usage for narcoleptics or severe daytime sleepiness sufferers is only for symptomatic therapy. It's only symptomatic therapy because there is nothing for the actual mechanism that causes narcolepsy or excessive daytime sleepiness. Amphetamines are medications used in the management and treatment of ADHD and narcolepsy. They're classified as central nervous system stimulants, which functions by increasing the amounts of dopamine, norepinephrine, and serotonin in the synaptic cleft, which is a nerve terminal, through a variety of mechanisms. Popular amphetamines include Adderall and Dexedrine. You can expect increases in sleep latency and REM sleep latency and decreases in REM sleep quantity. These also work as monoamine oxidase inhibitors, MAOIs. They're also commonly abused due to powerful euphoric effects. These are the things that are in Breaking Bad. Methylphenidate is a non-amphetamine stimulant designed to mimic amphetamine. It blocks the reuptake of two neurotransmitters in the presynaptic neurons, norepinephrine and dopamine. More specifically, it stops the transporters of these neurotransmitters, increasing the concentration of dopamine and norepinephrine in the synaptic cleft. Whenever you shut the door on something that is supposed to have more coming in, you're going to have a lot of buildup. It's like a dam. These drugs make a dam for all the nice, happy, stimulating brain chemicals, and all of a sudden that dam bursts, and now you've got tons of that stuff. That's how stimulants work. Popular brands include Concerta, Metadate, Methylene, and Ritalin. These drugs are used to treat ADHD and can be used as a second-line treatment for adult narcolepsy. Some of the specific side effects would be insomnia and nervousness. Modafinil is a non-amphetamine central nervous system stimulant with wakefulness-promoting properties. In the United States, modafinil is FDA approved for the treatment of narcolepsy. The brand names are Provigil and Nuvigil. A potential advantage of modafinil and armodafinil is its very low observed propensity for causing euphoric effects associated with traditional psychostimulants, so it's less likely to be sought out for recreational use. It doesn't make you feel good. It just makes you sleep when you use it the right way. It's also used to treat narcolepsy, sleep work shift disorder, and the residual effects of obstructive sleep apnea when used with OSA treatment like CPAP. Regarding serious adverse effects, cases of Stevens-Johnson syndrome, which is a toxic epidermic necrolysis, which is a rare acute skin condition in which there are sheet-like skin and mucosal, you lose it, accompanied by systemic symptoms. Medications are causative in 80% of these cases. Sometimes it can be fatal. Overall, there's no change in sleep architecture because of these drugs, but it can increase sleep latency. Everyone's favorite, caffeine. It's in most of the Starbucks drinks we get, partly because it increases dopamine levels. It is found naturally in chocolate, tea, and coffee. In the brain, adenosine promotes drowsiness. Adenosine builds up as the day goes along and creates sleep pressure, or that feeling that you feel when you need to sleep. Caffeine just so happens to be chemically shaped to fit inside those adenosine receptors and can block adenosine from making you sleepy. However, when the caffeine wears off, you have a buildup of adenosine causing a crash. When it wears off, that's what we call the half-life. The half-life is when the medication's effectiveness has worn off by 50%. When you stop using stimulants, it can lead to irritability and mood and performance disturbance. You can expect increased sleep latency and reduced total sleep time and N3 time. Cocaine was commonly used in medicine before the awareness of the addiction and side effects were researched. Cocaine works by blocking monoamine reuptake, namely dopamine, norepinephrine, epinephrine, and serotonin. This buildup of happy transmitters leads to prolonged sympathetic effects. Cocaine may create euphoria with increased energy and motor activity. It'll enhance feelings of competence and sexuality. The effects generally last 15 to 60 minutes. Some users will stack doses one after another and experience cocaine runs, which can cause continued and prolonged wakefulness. Once the effects have worn off, there is a crash that can be accompanied by excessive daytime sleepiness and excessive sleep. Currently, the only medical use is in ophthalmological, oh my god, I'm having trouble saying words again. Ophthalmological. The eye doctor, anesthesia. Gosh, I don't need to be doing this late at night. In the late 1800s, it was used for everything like a cure-all. It was only in the 1920s when the Dangerous Drugs Act was passed that cocaine was limited in its medical purposes and just illegal elsewhere. With cocaine, you can expect changes to insomnia and disrupted sleep, but also increased total sleep and REM sleep associated with just coming off of it. Nicotine can be found in tobacco like cigarettes, cigars, snuff, and chaw, and synthetic nicotine is found in products like patches or vaporizers or e-cigarettes. Nicotine affects the brain by releasing dopamine in the frontal cortex, which delivers a pleasurable experience. Cholinergic agonists means a chemical that binds to an acetylcholine receptor, which relays feelings like warmth, euphoria, and reward. The nicotine half-life lasts about 2 to 3 hours, but it is highly addictive and with tolerance and dependence that increases with chronic use. We expect nicotine to decrease REM sleep and total sleep time and increase sleep latency. Quitting nicotine is difficult. Withdrawal symptoms can be associated with sleep disturbance, diaphoresis, which is excessive sweating, and insomnia. Cigarettes and tobacco smoking products come with the added issue of inhaling tar and other toxic particulates. Cigarettes used to just be dried tobacco leaves that were cured and rolled, but now they're heavily processed and they may contain pesticides and other additives that are extremely harmful. Vaporizers, on the other hand, have the potential to contain many times more of the nicotine than the typical cigarette. There have been deaths linked to vaporizers, but there were like 68 deaths a few years ago, and those all appeared to be vaporizers that had vitamin E in them, and when you inhale that, it can cause popcorn lung. So vaporizers are dangerous because there's no telling where the nicotine is sourced from or where the flavors come from. The FDA does not regulate vaporizers or nicotine liquid. Nicotine can also increase blood pressure, pulse, and brain activity. Nicotine can also decrease breathing depth, so you might have more shallow breathing. Tetrahydrocannabinol, or THC, has been around for thousands of years and has been used for medicinal purposes since ancient times. There are many street names for THC, and the plant flowers like marijuana, which is not a scientific name at all. Weed, trees, grass, all those things. Due to its recent legality in certain states, the accessibility has been lifted just enough to allow more research to conclude the overall effects of THC use. Remember, just because a substance is illegal doesn't mean people won't do it. THC is found in the cannabis plant and in low doses of the hemp plant. Contrary to the common picture of the leaf, the flowers or buds are smoked, not the leaves. They can also be processed into a variety of products, including vaporizers, tinctures, drinks, and edibles. There are two types of cannabis. One is called sativa, which gives you an awake effect and more of what they would call a head high. And indica, which creates a sedating effect, which I guess would be more of a body high. So obviously you would have a different reaction on sleep depending on which one you would ingest. And generally these two types usually combine to make a product. I don't think you have just a general sativa and a general indica. It's a mix. Overall, you can expect low doses of THC to suppress REM, increase N3 sleep and total sleep time, but architecture returns to normal after a week of abstinence. As far as studies have concluded, THC is not an addictive substance and does not have severe withdrawal symptoms. However, THC does come with some side effects, including dry mouth, hallucinations, slower reflexes, and changes in perception. If it's smoked, there's no denying that you're still smoking something, and that smoke gets in your lungs, and that's not good for you. Cannabinoids are a group of chemicals found in hemp, or cannabis plants, not THC, this is a different kind, and are federally legal because they do not have more than a specific amount of THC present. Like THC products, CBD products can be processed and made into analgesic, topicals, edibles, and they can be smoked. Like THC products, CBD is not federally regulated, so the products may vary on their ingredients. Unlike THC, there is no high or sense of euphoria or change in perception. CBD has been shown to improve insomnia by helping sleep onset and sleep maintenance as well as increasing total sleep time. Although it is not considered as potent as THC, it can still increase mental sedation and cause dry mouth, reduced or increased appetite, drowsiness, and fatigue. There are a broad array of stimulants, and they can all have different effects. In general, stimulants are expected to decrease sleep efficiency, N3 sleep, and REM sleep. They are expected to increase sleep latency, wake after sleep onset, N1 sleep, and REM latency. Before the 1950s, opioids and amphetamines were used as antidepressants, but those were discontinued due to the side effects and addictive nature, not to mention they didn't really work other than masking the symptoms. It wasn't until later in the 1950s that real antidepressants were manufactured specifically for the treatment of symptoms of major depressive disorder. The mechanism of antidepressants is still highly controversial because there are no studies that have clear evidence that show depression is caused by a chemical imbalance in the brain, which antidepressants are purported to treat. However, enough evidence shows that patients' depressive symptoms improve on these substances, and really that's enough until the drug is shown to be toxic or ineffective. If it helps a patient, isn't that good enough? In general, antidepressants are used to treat depression, panic attacks, anxiety, and compulsive obsessive disorders. They can also be used for off-label purposes such as patients with chronic pain, pain disorders like fibromyalgia, eating disorders, and post-traumatic stress disorder. These agents typically interact with one or more neurotransmitters, namely serotonin, norepinephrine, and dopamine. Each class of antidepressant has their own set of side effects. Despite all the differences, most antidepressants take at least 2 weeks to take on the true effect. Taking more than the therapeutic dose of antidepressants can be fatal due to their tendency to change the conduction of the heart, meaning the electrical conduction. They can become sedating to the point of respiratory failure, and they can induce seizures. Selective serotonin reuptake inhibitors, or SSRIs, are the first-line treatment for mood depressive disorders and dominate the market of antidepressants, mainly because they don't have as many side effects. Other off-label uses include, but are not limited to, binge eating disorder, body dysmorphic order, fibromyalgia, premature ejaculation, paraphilias, and autism. Some common brand names are listed here with the generics in the parentheses. Serotonin is one of the chemical messengers, or neurotransmitters, that carry signals between brain cells. SSRIs block the reabsorption of serotonin in the brain, making more serotonin available. SSRIs are called selective because they seem to primarily affect serotonin and not other neurotransmitters. SSRIs have little effect on other neurotransmitters such as dopamine or norepinephrine. Sleep-wise, SSRIs will block or suppress REM. Prozac sees more sleep disturbance early in treatment but will reduce over time. Overall, SSRIs will decrease REM sleep, N3 sleep, and sleep continuity, meaning more disruptions in fragmentation. Because they suppress REM, it is common to have increased REM latency and REM rebound at the end of the sleep period. Some SSRIs are known to induce bruxism, or sleep-related teeth grinding. Other side effects include insomnia, drowsiness, nausea, diarrhea, headache, anxiety, tremor, and sexual dysfunction, although these side effects may wane with continued use. The next class of antidepressants are called monoamine oxidase inhibitors, or MAOIs. An enzyme called monoamine oxidase is involved in removing neurotransmitters norepinephrine, serotonin and dopamine from the brain. MAOIs prevent this from happening, which makes more of these chemicals available to affect changes in both cells and circuits that have been impacted by depression. The most common side effects to MAOIs include dry mouth, nausea, diarrhea, constipation, headache. I feel like I'm doing an ad. Drowsiness, insomnia, dizziness, or lightheaded. Involuntary muscle jerks, low blood pressure, reduced sexual desire, weight gain, difficulty starting a urine flow, muscle cramps, and prickling or tingling under the skin. MAOIs are the strongest REM blocker of all antidepressants, and they can totally suppress REM. Vivid or abnormal dreams are also common if they occur. Heterocyclic compound antidepressants typically work like other antidepressants, namely blocking the removal or reuptake of serotonin and norepinephrine. They describe a range of antidepressants like tricyclic antidepressants and tetracyclic antidepressants. They have a variety of different ways they interact with different neurotransmitters. HCAs can promote different effects from highly stimulating to heavily sedating. Like any medication, it's important to document when patients are on cyclic antidepressants and when they take them. Tricyclic drugs or tricyclic antidepressants are a type of heterocyclic compound antidepressant. Tricyclic antidepressants treat major depressive disorder and are the second-line treatment behind SSRIs. Cyclic antidepressants ease depression by impacting chemical messengers, neurotransmitters, used to communicate between brain cells. Like most antidepressants, cyclic antidepressants work by ultimately affecting changes in brain chemistry and communication in nerve and brain nerve cell circuitry known to regulate mood and to help relieve depression. TCAs have a broader effect on neurotransmitters. They block the absorption or reuptake of the neurotransmitters serotonin and norepinephrine, increasing the levels of those two neurotransmitters in the brain, as well as affecting histamine and acetylcholine activity. Cyclic antidepressants also affect chemical messengers, which can lead to a number of side effects, which can include blurred vision, constipation, dry mouth, drowsiness, drop in blood pressure when moving or from a sitting to standing position, and urine retention. Other possible side effects include increased appetite leading to weight gain, weight loss, excessive sweating, tremor, and sexual problems. Overall, you can expect a decrease in REM sleep and an increase in REM latency, except for the antidepressant trimipramine, which seems to have no effect on REM. They can also increase non-REM 3 sleep. Selective antagonist and reuptake inhibitors, or SARIs, treat major depression. One non-FDA off-label usage is to induce sedation in patients with sleep problems. SARIs work by inhibiting serotonin reuptake in the brain. They act as antagonists to inhibit the serotonin receptors. It, in fact, is known by 5-HT2A receptor, and it blocks the function of the serotonin transporter protein, thereby increasing the amount of active serotonin throughout the CNS. They are primarily indicated for antidepressant uses, but they are also used for conditions like anxiety and insomnia. They don't have the side effects of other antidepressants, such as insomnia, anxiety, and sexual dysfunction. Overall, you can expect SARIs to decrease REM sleep, N1 sleep, arousals, and wake after sleep onset, but it will also increase REM latency and N3 sleep. Decreased sleep continuity means more fragmentation or sleep interruptions. In the end, most antidepressants have some form of effect on sleep in one way or another. Sometimes SSRIs will disrupt sleep, although the patient will report sleeping better. Slow rolling eye movements may be a characteristic antidepressant sleep study feature seen in non-REM, even after stopping administration. Here are some slow rolling eye movements occurring in non-REM 1. Well, slow rolling movements typically occur in non-REM 1. But here we see spindles, slow rolling eye movements with spindle activity. So that's in 2. But because this person is on antidepressant, we see that. Here's the overall final summary notes on antidepressants because they are quite prolific with sleep disturbances as people with depression and anxiety present with sleep problems. Most antidepressants prolong REM sleep latency. Or in other words, it takes the patient longer to get to REM sleep because the antidepressant has stopped REM from happening. Because of this, it may decrease overall REM sleep by 30%. As the drug wears off during the night, REM is no longer suppressed and it comes on strong with something called REM rebound, where REM cycles last much longer than typical. Antidepressants can increase movements during sleep, including periodic limb movements, restless limb syndrome, or REM behavior disorder. If a patient stops taking antidepressants, REM rebound will occur. Some newer antidepressants are popular because they tend to have less side effects, but it's not really known if they are more effective than tricyclic antidepressants. A characteristic of SSRI like Prozac are slow rolling eye movements like we just saw during non-REM sleep. Techs sometimes call those Prozac eyes. Cardiovascular drugs are a general group of drugs that affect the heart and or blood vessels. We're going to cover 2. Most of them are antihypertensives, and the other is a hypolipidemic. If you break down the word antihypertensive, hypertensive is high blood pressure, hypertensive is high blood pressure. Anti means against. So these drugs are trying to help high blood pressure. And they all do that in different ways. There are ACE inhibitors, angiotensin II blockers, beta blockers, calcium channel blockers, diuretics, and alpha-adrenergic agents. Sometimes it takes more than one antihypertensive to actually fix high blood pressure. Antihypertensives can work by affecting how the heart pumps blood. Some act as a vasodilator where the blood vessels are widened. And other antihypertensives are used to treat heart failure and prevent kidney failure. The first antihypertensives we'll cover are angiotensin-converting enzyme inhibitors, or ACE inhibitors. Sometimes with drugs you'll notice the suffix or the ending of a generic name, and they're similar. ACE inhibitors they end in prils: lisinopril, enalapril, and benazepril. So what are angiotensin-converting enzymes, and why are we trying to inhibit them? Well, there are 2 hormones that we need to know about, and those are AT1 and AT2, angiotensin 1 and angiotensin 2. Angiotensin-converting enzymes takes angiotensin 1 and converts it into angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor, or blood vessel squeezer, that makes your blood pressure go up. With people with high blood pressure, we can use ACE inhibitors to decrease the angiotensin 2 and its increase of blood pressure. Some of the side effects include nighttime coughing, sleep fragmentation, daytime sleepiness, increased sleep latency, and leg cramps. Thanks to learning about ACE inhibitors, we know about angiotensin 1 and 2. Angiotensin II blockers go straight for angiotensin II receptors instead of the middleman. These drugs end in sartans, losartan, valsartan. Angiotensin II blockers increase sleep latency and can cause insomnia secondary to leg cramps and coughing. Beta blockers work by blocking the action of epinephrine and norepinephrine, 2 neurotransmitters known for increasing heart rate and blood pressure. Epinephrine and norepinephrine bind to B1 receptors, which increase cardiac automaticity and conduction velocity. Beta blockers bind to the B1 receptors and block increased cardiac automaticity and conduction velocity. Hello, I said that twice. These generic drugs typically end in lol, not laugh out loud. Propranolol is more disruptive than other beta blockers. Generally, beta blockers may increase wakefulness, total wake time, and N1 sleep. they also may decrease REM, N3 sleep, and total sleep time. Beta blockers can also be associated with nightmares, with the exception of Nadolol, which actually seems to improve sleep efficiency and enhances REM without the side effect of nightmares. Calcium channel blockers work by reducing the amount of calcium available to the muscle cells in the blood vessel walls. Calcium in the heart cells increases the strength of cardiac contractions, so calcium channel blockers obstruct the entry of calcium and therefore reduces the cardiac strength, reducing blood pressure. These generic drugs end in pine, like amlodipine, P-I-N-E. You can expect a reduced total sleep time and reduced sleep efficiency, as well as drowsiness and GERD for side effects. Diuretics work by reducing the blood volume. If you don't have so much blood, you can't put too much pressure against the walls. And the way diuretics reduce the blood volume is reducing the water in the blood, specifically water from cell walls, interstitial water. And it deposits them into the bladder, making the patient pee more. Because of the increased urination, the patient may wake up more in the middle of the night to pee. There also may be increased wake after sleep onset because of it. Diuretics may also decrease the severity of sleep apnea. What? How does it decrease sleep apnea? Well, overnight, water displaces from your body and moves around because you're not up and down anymore. You're horizontal. And it could travel from the legs to the neck and cause pharyngeal inflammation. And boom, we're sleep apnea. Generic diuretics typically end in "ide," like hydrochlorothiazide or HCTZ, which is a super popular first-line treatment for blood pressure. Hypolipidemics, break it down. Hypo, under or reduced, lipid is fat, and emia is disorder. So hypolipidemic drugs are used to reduce the amount of lipids or cholesterol in the blood. Excess lipids against the organs is one thing, but lipid buildup in the blood can lead to blood clots and heart attacks because of the buildups in these blood vessels. These drugs are known for the suffix statins, like simvastatin and atorvastatin. There is no data to show sleep architecture changes, but they may lead to insomnia or disruptive sleep. Here are a couple nifty tables that have names of the popular hypertensives in their classes. Pay attention to the suffix or the ending of each generic name. Sometimes they can give away the class. Histamine is a chemical that activates different parts of the immune system when it encounters a foreign agent or allergy. It's responsible for runny noses, congestion, and inflammation, trying to keep whatever's irritating the body out. Sometimes the body overreacts and is susceptible to certain allergies and unnecessarily tries to help, but it just causes a mess instead. Antihistamines block the histamine from reaching their receptors. It can cause sedation and drowsiness, so many people use it as a self-prescribed sleep aid. However, patients should be cautioned against this as a sleep aid. Other side effects may include dry mouth, altered mental state, confusion, and urinary retention. Now, there are two specific histamine blockers that we need to be aware of. And there are two antihistamine drugs. The first are antihistamine 1 blockers, like your typical seasonal allergy drugs. These are the ones that we know. These histamine receptors are found in mast cells. Benadryl, Claritin, those are antihistamine 1s. Histamine 2 is found in the stomach and has to do with the amount of acid in the stomach. So it's a totally different thing. Antihistamine can be sedating, non-sedating, or have ingredients that attempt to make the drug less sedating, and that's why you can only buy a certain amount of specific antihistamines at the pharmacy, because some of them have meth in them. Typically, an antihistamine is sedating if the drug crosses the blood-brain barrier. That is the tipping point. That's the difference between if they make you sleepy or not. First-generation antihistamines, like Benadryl, cross the blood-brain barrier, therefore they can make you sleepy. They also increase daytime sleepiness and total sleep time. Second generation antihistamines do not cross the blood brain barrier and do not cause a sedating effect. All these antihistamines can be found over the counter unless you get them with meth in them. Then you have to show your license. Not too long ago, all these second generation antihistamines required a prescription. Second generation antihistamines may increase REM and N3 sleep and sleep efficiency. Overall, unless differently indicated, you can expect antihistamines to decrease sleep latency and REM sleep time and increase total sleep time and non-REM sleep time. That's a lot of drugs. Join me next time and we'll talk about some more.